This conference will now be recorded.
Hello, and welcome to this session called Continuous Glucose Monitoring in Pregnancy, Part 1. My name is Diana Isaacs. I'm a clinical pharmacist. I'm also the co-director of the Endocrine Disorders in Pregnancy Center, as well as the CGM Program Coordinator at the Cleveland Clinic. These are my disclosures, and you can also see this disclaimer here as well. And in terms of our learning objectives today, we are going to review glucose targets in pregnancy. We are going to describe the currently available continuous glucose monitoring options. We're going to discuss CGM accuracy as well as the clinical outcomes when used in gestational or pregestational diabetes. And we are also going to utilize CGM data to optimize treatment for a person with diabetes in pregnancy. And because there is so much content to cover, we are splitting this up into a part 1, and then there will also be a part 2. So before we dive into the glucose monitoring component, I think it's important to reflect on, well, why do we care, right? What is the problem with, high glucose in pregnancy, right? And we know, unfortunately, that it can lead to a number of complications, both for the baby and for the mother. So for starters, we see large for gestational age babies, which can lead to a host of problems like shoulder dystocia. There can be stillbirth, a higher incidence of C-sections, as well as neonatal hypoglycemia. And then in terms of mom, that can lead to retinopathy, preeclampsia, more episodes of diabetic ketoacidosis. And then the treatment, of course, our treatment of choice being insulin. If we don't get that quite right, that can lead to concerns with hypoglycemia. So managing to get to the targets is really, really important. So we have a number of organizations that, have recognized glucose targets in pregnancy, and there are some slight differences, but more often than not, they are pretty similar based on the research and the evidence that we have available. So we've got ACE, the American Association of Clinical Endocrinology, the ADA, American Diabetes Association, and Endocrine Society. And in general, ACOG is pretty in line with ADA in terms of the goals. And so for most people, we're aiming for less than 6 or less than 6.5% A1C. But we know A1C has a lot of limitations. It's based on red blood cell turnover. Often it does run lower in pregnancy, and it's also based on an average glucose. So A1C alone, unfortunately, is not really enough to know the day-to-day fluctuations. So typically we recommend for women to check fasting glucose, and we're aiming for that to be under 95 for within the most organizations, or even under 90 if possible. And then 1 hour postprandial is typically when we expect that peak postprandial glucose to occur. And we're really trying to keep that under 140, and all the organizations agree on that. And then 2 hours, we would expect that glucose would be starting to come down a little. And so if a woman is checking at 2 hours, we would really want that glucose to be under 120. And for most women doing finger sticks, they're advised to either do 1 hour or 2 hour postprandial and try to meet these targets to have the best possible outcomes. And then continuing on, we have, there's a bunch of recommendations about the use of CGM in pregnancy as well. And so ACE, basically states that use may be recommended when patients are unable to achieve target glucose with SMBG or self-monitoring of blood glucose alone. And they acknowledge that it is associated with improved glycemic control during the 3rd trimester of pregnancy, reduced infant birth weight, and decreased risk of infant macrosomia. And ADA acknowledges that CGM can help to achieve A1C targets in diabetes in pregnancy. You'll notice it says when used in addition to SMBG. And when used in addition to SMBG, CGM can, again, reduce macrosomia as well as neonatal hypoglycemia in pregnancy complicated by type 1 diabetes. And the Endocrine Society says to use CGM when SMBG levels are not sufficient to assess glycemic control. And I also want to acknowledge that ACE recently put out a new statement about technology use in diabetes, and they strongly advocate actually for every, pregnant woman, whether gestational diabetes or, type 1 or type 2 diabetes that is now pregnant, that if they are on insulin therapy, they should be using CGM. So I like to show this to really illustrate the difference between SMBG versus CGM. And what you are looking at here is a 24-hour period, essentially looking at 12 a.m. to 2400 or to midnight. And this represents a person who is checking their glucose with finger sticks 4 times a day. Now, this is set, in this example, this is set for 70 to 180, which is usually the target for non-pregnant people with diabetes. And, you look at something like this and you say, okay, well, these appear to be, in target. But when you put CGM on a person, you start to see everything that is happening in between those dots. And, in this example, we note that there's actually undetected hyperglycemia happening between those glucose checks, as well as undetected hypoglycemia. And, it's common when we put CGM on a person that we notice all these things that we missed with finger sticks, because, even for a person that's checking finger sticks, 7 times a day or more, you're still not getting all the data that you get with a continuous glucose monitor, which on average checks glucose every 5 minutes. So if you do the math, that is actually 288 glucose readings a day, which is just a whole lot more information. So we have 2 types of CGM devices. There is real time, and that is when the sensor data is transmitted continuously to a receiver or a display device, which allows for real-time alerts and alarms when glucose is, goes high or goes low. And to just back up a second, CGM essentially has 3 components. There is a sensor, which is the part that's just beneath the skin in the interstitial fluid, which is different from a glucometer, which measures glucose from capillary. So it's in the interstitial fluid, and I like my patients to know that it's not that there's a needle staying in you. It's actually very soft. You can think of it kind of like an eyelash, but that is what is sensing the glucose value and then communicating with a transmitter, which is on top of that sensor, and that communicates to some type of receiver or reader, or in many cases, a smartphone can be used, or an insulin pump can be used to receive that information. So real-time CGM, that device is always transmitting. Intermittently scanned CGM is a little bit different because the information is only available when a person scans. So if a person can scan as often as they want, but they do need to scan to see that glucose level. And one of the things to know about the current devices is that the sensor essentially holds 8 hours of information. And if it's not scanned in those 8 hours, that information will not be able to be downloaded. So it is an important counseling point for patients to be scanning at least every 8 hours. Otherwise, when we try to look at their information, we will not be able to see it. So these are the current CGM options that are FDA approved, and we're going to go through these in more detail, but you can see pictures at the bottom. And for starters, we have the Dexcom G6, which is right in the middle, and this is a 10-day wear, and what you see in the picture is actually the transmitter. So some devices like the Libre on the right have our combined transmitter and sensor and fully disposable. The Dexcom G6 has a reusable transmitter. It's actually kept for 3 months, and then after 3 months, it's discarded and placed with a new transmitter. And Dexcom G6 is a real-time CGM. On to the right of the G6, we have the Guardian Connect, as well as the Guardian 3. They look the same. The Guardian Connect is a standalone CGM that works with a smartphone, and the Guardian 3 works with the Medtronic insulin pumps. But what you see there is actually the transmitter is on the charger. So this transmitter is also attached to a sensor, and this transmitter is good for like a year or longer, but it does need to be charged every week in between use. Now, to the right, we have the Libre, and there is a Libre 14-day as well as a Libre 2, and they look identical. They are about the size of two stacked quarters. Even though they look identical, they are not interchangeable, so they do work a little bit differently. But this is our disposable device, and this is an intermittently scanned CGM. And then all the way on the left, we have the Eversense implantable. And this one is pretty unique because the sensor, which is what you see in that hand right there, is actually implanted into someone's arm. And currently it is a 3-month wear, although in Europe it is approved for 6 months. And I know they're working on having a 1-year wear, but it does require an in-office procedure. And then to the right, you see there that is a transmitter, and that transmitter is placed on the arm just over where that implanted sensor is. Now you might be thinking to yourself, well, why would anyone use that if you still have to put a transmitter on the outside? Well, one of the reasons that does make this appealing is that with the other sensor transmitter combinations, the way they are inserted, it is not easy to just remove them. Well, actually it is easy. You can pull it off like a Band-Aid, but unfortunately it is not cheap to do that because you need to have a new insertion device each time. So therefore, once someone puts it on, they're pretty committed to keeping it on the full 7 to 14 days. Otherwise, they're going to probably run out of supplies or incur extra costs. With the implantable CGM, that is very easy to remove. And so someone could remove it if they wanted to, if they're taking a shower or for other reasons. Just something to note, these are all waterproof, so they do not need to be removed for shower or bathing though. So let's talk a little bit more about the differences between the respective devices. So for starters, insulin pump integration. Many people are using insulin pumps, and so the Dexcom G6 is integrated with the t:slim X2. And this pump has, or there's two options with this pump. There is basal IQ, which suspends insulin if glucose is predicted to go below 80. And then there is control IQ, which actually attenuates insulin. It can increase or decrease to try to keep glucose in the target range of 112.5 to 160. I will tell you, for pregnancy, we usually don't use control IQ because the targets are a little high for pregnancy. However, basal IQ is more commonly used and can help reduce the risk of hypoglycemia. In addition, we also have the Guardian 3 integrates with the Medtronic 670G and 770G pumps. And these are hybrid closed loop systems, just like the Control IQ with Tandem, where it auto adjusts insulin levels to meet the glucose targets. And again, the targets with these hybrid closed loops are also pretty high for pregnancy. So often when women are using these pumps, they would probably go out of what we call auto mode and use it more in manual mode. But the point is, you can see the CGM glucose data directly on the pump. The others at this time do not have the direct integration, although I do think it's important to note that both Libre 2 and Dexcom G6 have something called a classification called an iCGM, which means it is an integrated CGM. It means that the FDA has basically deemed that the accuracy is good enough that it can integrate with other devices like insulin pumps and connected pens. And at this time, the G6 does integrate with InPen, and the Libre 2 integrates with a pen cap, a connected pen cap called Bigfoot Unity. And even though the Guardian Connect does not technically have this iCGM status, you can see it does integrate with the pump, and it also does work with the InPen. Now, for receivers, the Libre 2 has a reader as well as the Libre 14-day. The G6 has a receiver. The Guardian Connect and the Eversense do require that someone has a smartphone, and they do work with Android or iPhone, but someone does need to have a smartphone and does need to download the respective app. At the current time of this presentation, the Libre 2, we are still waiting on a mobile app. So anyone using that system really needs to have the reader, versus those using the other systems like the Libre 14-day or G6 can choose if they want to use a separate device or just use it on their smartphone. Now, there's differences in the wear time. 7 days for Guardian, and then 10 days for G6, 14 days for both of the Libre devices, and 90 days for Eversense. And then there's also differences with the warm-up time. So warm-up time is after a new sensor is inserted, there is a warm-up where a person cannot see their glucose readings. And for Libre, it's 1 hour. For Dexcom G6, it's 2 hours. Guardian, it's up to 2 hours, and Eversense does have a full 24 hours. Calibrations. So what calibrations are they are required finger sticks to make sure that the device is, working properly and ensure the accuracy. G6 and Libre are factory calibrated, meaning there are no calibrations required. The Guardian requires at least 2 per day, and often 4 will make the algorithm run more optimally. Eversense also requires 2 finger sticks per day. The G6 does have an optional calibration. If someone notices their sensor readings are far off from their finger stick readings, they could do a calibration, versus the Libre does not have that feature, but the reader does have an option to check a finger stick and record that data, but it is not actually used to calibrate the device. And then in terms of data downloads, each CGM has their own data system. So for G6, there's Clarity. Libre utilizes the Libre View. Guardian uses CareLink, and Eversense has the Eversense data management system. There are also what we call agnostic systems like Tidepool and Gluco, which work with multiple systems. So that can be, if you're utilizing many different CGMs, you could work with one system instead of each of the separate. Continuing on, we have something called a non-adjunctive indication, and this is granted by the FDA when it's deemed that the device is accurate enough to dose insulin off of, such as, correcting a high glucose with insulin. So all of the devices have this indication, with the exception of the Guardian Connect and Guardian 3 do not at this time. The MARD describes the accuracy, and this stands for mean absolute relative difference, and this compares the sensor glucose readings to what we call the gold standard, which is a venous lab draw. So the lower the better. And generally the FDA will say, if the MARD is below 10%, that is accurate enough to dose insulin. The reason why there's a couple stars by the Guardian is that the MARD is 9.64 with up to 4 calibrations per day. If someone does less calibrations on that, then the MARD actually is higher. I will say it is not fair to compare MARD from system to system because it depends on the data points used. So unless they are in the exact same study, I cannot actually look at this and say, well, Eversense definitely has the best accuracy, because they weren't studied directly head to head. That being said, I can tell you the data for the Libre 2 compared to the 14-day shows that the Libre 2 is more accurate. And I can also tell you from my personal experience and using this with patients, especially in the lower range, the accuracy tends to be better compared to the original 14-day. And then there's a bunch of drug interactions, and especially I want to make note of the acetaminophen with the Guardian, because many pregnant women could be taking acetaminophen at different times, and so that can falsely elevate those sensor readings and would be really important for the woman to know and to make sure she's verifying with finger sticks. Other interactions include vitamin C with the Libre. And you'll notice salicylic acid is listed for the original 14-day Libre. And salicylic is what is an aspirin. And, a woman could be taking a low dose aspirin for preeclampsia. However, that is not a concern. This is only at doses 650 milligrams or higher. So a low dose aspirin is not expected to interact. And then hydroxyurea has a couple interactions, not a drug so commonly used for some cancers and sickle cell anemia. And then you can see the mannitol and tetracycline with Eversense. Alarms, so all the devices have some type of alarms. They're a little different between device in terms of predictive ability and different features. The exception is the Libre 14-day. The original does not have any alarms. So speaking of alarms, I want to mention the value of alarms in real-time data. So, in addition to just getting a whole lot more data points, I think one of the real values of CGM are these arrows. And what the arrows tell you is how quickly glucose is rising or falling. And so when you see an arrow that's horizontal, a person can feel rest assured that their glucose is pretty steady. But when you see an arrow going straight down, or with some systems, it could be double arrows down or triple arrows going down, that means glucose is dropping really quickly. And so generally, depending on the system, that could mean, it could be dropping by 2 to 3 points per minute or more. And so if you do the math, 30 minutes out, a person could be 60 or 90 points lower. And I think this is really important because let's say, the woman checks her glucose before bedtime and it's 120. So she's like, okay, that's acceptable. I can go to sleep. But what if she's wearing CGM and it's 120 with double arrows going down? That means in 30 minutes, she could be 90 points lower. And so that is very, very helpful, in addition to having the alarms. And the alarms are customizable. So, they can be set, depending on the device, they can be set in a wide range. And so, some women may want to know earlier, they may want to know at 75, 80 even, or 70. And then some really don't want to know until it's much lower. Many of the devices have a hard set alert at 55 when it reaches 55. Some devices have an urgent low soon alert feature where it can actually let you know, for example, if it's set to reach 55 in the next 20 minutes, that alarm would go off. And you could imagine alarms like this can, be potentially life-saving. Let's talk about the approved sites. I think there's some misconceptions about this. So each device does have their FDA approved sites, and I've listed them out here for you to see. We've got, upper arm, abdomen, upper buttocks area. But as a clinician, you can use your judgment that there may be a site that is better. I mean, the important thing is it needs to be an interstitial fluid. And these are how the devices were tested. And so when you look at their accuracy, that's what they were approved for. But many times a different site is going to work better. And especially in pregnancy, often it is uncomfortable to put it on the abdomen. And I'll talk in a little bit about some of the accuracy comparisons between the sites. But just know, as a clinician, you can use your judgment. You don't necessarily have to, only keep it at the FDA approved site, when in reality, I mean, we're talking about CGM use in pregnancy, which technically is not FDA approved at this time anyway. So all of this is off label, but rest assured it is approved in Europe. And, the hope is that in the future, we will have FDA approved devices as well. So next, I want to talk about the standardized CGM metrics, because we get a lot of data from CGM and it looks different than some of the data we're used to looking at with typical blood glucose monitoring. So when you look at a report, you're going to see things like, the number of days the CGM is worn and the percentage of time the CGM is active. And there's an international consensus on time and range that came up with a consensus of, well, what is the ideal when a person is wearing CGM? Now, they recommended, when you're looking at data, to have 14 days with at least 70% of the available data. And the reason they made that recommendation is because when you're interpreting certain metrics, having more data is better. You could imagine if you only had 25% of the available data, then interpreting things like the average glucose, you're missing all that data, so it's not going to be as accurate. Now, you might be asking yourself, well, wait, why wouldn't I have all the data? Like, why would I only have 70% of the data? And there's various reasons. I mean, the most common one is, is the person wearing the device? So after, if the person decides to take a break in between sensors, that could be a reason. The sensor warm up is pretty minimal. You're looking at 1 to 2 hours for most devices. So that's not a huge reason. I would say the most common are falling off early. or not putting a new one on right away, with the exception of the intermittently scanned, we know requires that every 8 hours of scanning at least. And so if a person is not, scanning frequently enough, that could be a source of missed data. Now, we have some new terms. This glucose management indicator, or GMI, is actually a CGM derived estimate of the current A1C level. And so this is really helpful to kind of put into perspective of, how a person is averaging. And it's nice because, A1C, for many non-pregnant patients, we're only getting it quarterly. In pregnancy, we will sometimes get that more often, but it's a nice way to check in. I mean, you can even update it, every 2 weeks to see where that average, A1C is running. And then the other very useful metric is this coefficient of variation. This is a measure of glycemic variability. And if you're wondering about the specific formula, it is the standard deviation divided by the mean glucose. And we are looking for it to be under 36%. And this is basically a marker of the roller coaster. Is the person going up and down all the time, or is glucose more steady? And this is very unique to CGM that we do not get with A1C, which is just an average. And we know that it's certainly not ideal for someone to be having this roller coaster, as well as it usually indicates this person is having more hypoglycemia if they have a high coefficient of variation. So in addition to those key metrics, we have what is particularly the most useful, which is time in target range. And in pregnancy, the target range for CGM, according to the International Consensus on Time in Range, is 63 to 140. And we are trying to maximize that time. And then time below range is under 63, and time above range is over 140. For completeness, I wanted to include what the target ranges are for, people that are not pregnant, which is 70 to 180. And then it is split up into level 1 and level 2 hypoglycemia and hyperglycemia when it's under 70 and when it's over 180. So what are the goals for all of this? Well, fortunately, we have guidance. And so going straight to the pregnancy on the right, for a woman with pre-existing type 1 diabetes, the goal in that target range is to be there at least 70% of the time, while trying to minimize that time below 63 to under 4%, and really trying to minimize that level 2 hypoglycemia under 54 to less than 1% of the time. And then over 140, we are trying to minimize to less than 25% of the time. I find this very reassuring and try to make sure I show all my patients this, because what you'll take note of is that we're not asking for perfection. You're basically recognizing that it is really challenging to, meet the targets all of the time when you have type 1 diabetes. And so if a woman can be there at least 70% of the time, generally that is associated with, positive clinical outcomes. Now, you might be asking yourself, well, wait, what about gestational diabetes or, pregnancy of type 2 diabetes? And unfortunately, the international consensus on time in range could not come to consensus by this because, or I should say rather, the organizations that were also involved in endorsing it could not come to consensus because unfortunately, we just don't have enough evidence to say what is best. There was some talk about trying to aim for 90% or more time in target range, but we really lack the evidence in there. So what I can tell you is, of course, you want to aim for at least 70% in that target range. And if you can safely get higher, that is, always going to be desired while minimizing hypoglycemia and hyperglycemia. So let's now take some time and explore the existing data that we have about CGM in pregnancy. And as we go through this, what I want to put in perspective is that CGM is a very quickly growing area. I mean, we've really only had these devices for about 20 years. And the first, which might sound like a long time actually, but really up until the last 5 years, the devices were far from optimal. I mean, they really lacked the accuracy that we have today. I mean, when you look at the accuracy, the ease of use, the not requiring all these calibrations now, they've really come a very, very long way. So thus, this makes it a very new area to explore, and studies are ongoing to build more evidence. But regardless, I'm going to share with you what we have, even though some of this is with the older devices that didn't work as well, starting with this first study by Castilla and colleagues out of Finland. And this looked at CGM in women with gestational diabetes, comparing that to, self-monitoring of blood glucose. And they really didn't find much of a difference. When they looked at the maternal and fetal outcomes, there really were no differences between the groups. That being said, the group that used CGM actually was much more likely to start medication, 44%, compared to only 8% in the SMBG group. So why was there no differences? We don't really know. Maybe it wasn't powered to see the differences, but regardless, that was the result there. Now, the second study by Murphy and colleagues out of the UK looked at women with type 1 and type 2 diabetes in pregnancy, again compared CGM with SMBG. This was a little bit different. They actually used a blinded CGM. And what a blinded CGM is, where the person wearing it doesn't actually see the results. So they don't get the alerts for highs and lows, but the clinical team sees it and can use it to adjust, make recommendations for the insulin adjustment. So in wearing this, every 4 to 6 weeks, there was actually an A1C reduction in the CGM group, only at that 32 to 36 week mark, but there were actually significant improvements, being a decrease in macrosomia and a decrease in birth weight with the CGM group compared to the BGM group. And then the last one on this slide by Setcher and colleagues out of Denmark in 2013, again looked at type 1 and type 2 diabetes, comparing CGM and SMBG. And this was actually used real-time CGM, so this was not blinded, but the woman didn't wear it all the time. So they got to wear it like 5 separate times, but they weren't wearing it all the time. So it was like intermittent use of real-time CGM. And so for glucose outcomes, there were really no differences. I mean, there were really just no differences between the groups, which, is a little disappointing. There was note that, there was increased neonatal hypoglycemia with maternal hyperglycemia, which is, something that we know can occur. Now, going on, and I should have mentioned, these are all the randomized control trials. There are other, observational studies, lower quality studies, but these are the RCTs that we have available. So GlucoMoms was out of the Netherlands, and this was studied in women with type 1, type 2, and gestational diabetes, again, comparing the two groups. And this was also a little different. So they used blinded CGM, but they had the woman wear it consecutively, they had them wear it every 6 weeks throughout. So, but it was blinded. So for glucose outcomes, there was actually no significant differences, but they did note that there was decreased preeclampsia and decreased hypertension in the CGM groups. So that did have a positive outcome. And then the last one in our most robust trial in pregnancy is the concept trial. And so I'm going to spend some more time going through this in more detail. This is our most recent one from 2017. This was specific to type 1 diabetes in pregnancy, but this used real-time CGM daily throughout the pregnancy. And, kind of top line results, there was a decrease in A1C. There was increased time in that target range of 63 to 140, decreased time over 140. And then these really, these larger outcomes, there were decrease in large for gestational age babies, decrease in NICU admissions over 24 hours, decrease in neonatal hypoglycemia, and decrease infant hospital stay. And all of these, right, are so important because those also, decreased health system costs. And so this makes a very strong argument about, certainly covering CGM for pregnant women, at least with type 1 diabetes. So let's talk about this one in a little bit more detail. CONCEPT stands for Continuous Glucose Monitoring in Pregnant Women with Type 1 Diabetes, and their objective was to assess the effectiveness of real-time CGM on maternal glucose control, obstetric outcomes, and neonatal health outcomes, and their primary outcome was actually change in A1C. And this was a very large prospective open label RCT that occurred on 31 hospitals in 7 countries. So this is pretty robust for a pregnancy trial. And it included women that were either planning pregnancy or that were already pregnant prior to 14 weeks pregnancy. And they were randomized 1-to-1 to CGM or just continuing SMBG. And they were also stratified by method of insulin delivery. So it included women using insulin pumps as well as injections. And then it was stratified by baseline A1C as well. So here are the baseline characteristics, and very similar between the two groups. I do want to acknowledge that, this wasn't a very diverse population. You'll notice that, the majority of women were of European origin. And then in terms of the duration of diabetes, very similar. Most of these women had diabetes for a long time. It was type 1 diabetes, likely developed in childhood. So the A1Cs at enrollment, you can see here, and by randomization, they had come down a little bit, but very similar between both of the groups, similarities in body mass index. And then I would say this was a pretty high, in terms of insulin pump usage, especially in the planning pregnancy group, 74%, pretty high insulin pump usage. So what were the glycemic results of the pregnancy trial participants? So you can see the baseline here at 24 weeks gestation, 6.23 versus 6.4. And the change from baseline to 24 weeks was 0.67 versus 0.52. And that was, it's not a huge difference, but it was statistically significant. And then continuing on with that, at 34 weeks gestation, you can see the A1C results, and these were also statistically significant when comparing the A1Cs at 34 weeks from the CGM group to the SMBG group. And this was the primary outcome. So there was a difference found there. When looking at A1Cs that were under 6.5% at the 34 weeks, there was a trend toward more in the CGM group of 66% versus 52%, although that in itself did not reach statistical significance. Now, continuing on with this, we've got time in range, which is, kind of like our primary thing that we're looking at with CGM data. And they were able to compare to the SMBG group by having them wear a blinded CGM so that they could directly compare. And so you'll notice at baseline, both groups were 52%. But by week 34, the CGM group was 68% and the SMBG group was 61%. And so that difference was statistically significant. I do want to point out, technically they didn't reach that 70%, right? They were really, really close to it. And I think that just reinforces that it's not so easy in type 1 diabetes. It is challenging to try to stay under 140 all the time. But regardless, this did show that the CGM group increased their time spent in that range. And then also the time spent over 140 was also reduced with the CGM group, which was also found to be statistically significant. And then what about hypoglycemia? So hypoglycemia, there was actually not a difference, which I guess is a little surprising. You hope with the alerts there might be, but overall, I think what you can see is there was a low amount in both groups. So, starting off, they experienced more, but by week 34, it was only 3% in the CGM group and 4% in the SMBG group. So technically, under 4% is goal. So they were meeting the goal. I think there happened to be a low amount in the SMBG group as well. And then the coefficient of variation, a trend toward improvement, meaning less variability. Lower, as a reminder, lower here is better. And the goal is to be under 36%. And there was not statistically significant, but a trend toward improvement. And this just shows, in terms of the CGM use was 70% in the pregnancy group and 77 in the planning pregnancy group, meaning they used it more than 75% of the time, just showing that, overall the adherence to the CGM was pretty good. And then what about those neonatal outcomes? Because, right, it's nice to see the glucose data, great that there are improvements, but those are really surrogate markers, right? We want to know that mom is healthy and baby is healthy. And so here is where it's really, really exciting, okay? So large for gestational age babies being in the greater than 90th percentile, you can see CGM group 53% versus 69% in the SMBG, which was statistically significant and puts it in an odds ratio of 0.51, meaning, 6 women, for every 6 women you treat, you're gonna prevent one LGA baby, which is, amazing, right? And then neonatal hypoglycemia that required IV dextrose, 15% versus 28%, also a huge improvement, and number needed to treat 8 for that. And then high level NICU care over 24 hours was 27% versus 43%. Also statistically significant, and also number needed to treat only 6. So really robust outcomes were seen from this trial. So with that, I am going to slightly switch gears now, and I'm going to share with you a little bit more data about accuracy in pregnancy, because I think this is what's kind of on everyone's mind, right? So is CGM going to be accurate enough for my patients? Can I rely on that? So, I'm sharing with you, remember, keep in mind, some of this is older data, but we have this first study, Chen and colleagues, all the way back from 2003 with a mini med, which is Medtronic. It was an older version though, and they compared 3 days of use to SMBG that was done 6 to 8 times daily, showing that the correlation coefficient was 0.94, and the closer it is to 1 indicates the better accuracy. So that was shown to be, pretty accurate. The one by Curson and colleagues in 2004, again, compared to MiniMed versus SMBG, and very similar, had this correlation of 0.96. We also have something called the Clark error grid, and zone A is the preferable range to be in, meaning it's clinically very similar. I'll talk more about the error grid in a second, but zone A is the most preferable, and then zone B. And then Scott and colleagues actually compared the Freestyle Libre 14-day versus SMBG and showed that the consensus error grid was zone A 88% of the time, and overall being in zone A or zone B was actually 99.8% of the time, and that MARD was 11.8%. So, it's a little higher than what it is in, from our other studies outside of pregnancy, but it was still, it's 11.8. So continuing on, we have the study by Gaddy and colleagues in type 1 diabetes that also compared Libre to SMBG. And here we actually see from this trial that the consensus error grid showed that, being in zone A or zone B was 99.8, but the MARD of this trial was 8.6%. So that was, lower. Again, I want you to just keep in mind that these trials are going to vary depending on what data points they used. So that's why sometimes you see differences. And then the Castorino trial, which was done more recently in 2020, comparing the Dexcom G6 to actually venous lab draws. So this was not directly to SMBG, which we know itself can have its own errors. And this showed that, 81% of the readings were within 15 points or within 15%, and the overall MARD was 10.3%. And then, we talked earlier about the different sites, and there was an interesting study done with the G6 that looked at these different sites in pregnancy, comparing the abdomen to the upper arm to the buttocks, and actually showed, if you look at the MARD, the second row, that the upper arm was actually 8.7%. And so this provides some good data to show that, in pregnancy, at least with the G6, the upper arm may be preferable to the upper buttocks or abdomen, where you can see that MARD was a little bit higher, being over 11 in those sites. So I want to just share some results about the Libre accuracy versus SMBG. And so this study included participants with type 1 diabetes, type 2 diabetes, and gestational diabetes, found overall that the MARD was 11.8%. And there was actually no difference in diabetes type, whether they had type 1, type 2, or kind of true gestational diagnosed in pregnancy. This shows you, though, the consensus zones, and I just wanted to share what this means. So, 88.1% of these readings being in zone A, this means there's no effect on clinical action. And, an example comes to mind is, a woman checks, fasting glucose, and the sensor says that it is 89, and maybe the finger stick says it is 84, right? Those are not the exact same. They're likely not going to be the exact same because one is interstitial fluid and one is, a capillary. But those are similar and they're not going to make changes in treatment. Now, zone B means that there could be altered clinical action, but there's not expected to be any effect on the clinical outcome. And so, an example I like to think of is if a woman has a correction dose, and she checks her glucose and sees that it is, let's say, 150, but actually, if she were to do a finger stick, it's 170, and she's going to give herself a correction dose. It could be, if she knew it was 170, she'd give herself a little bit more insulin, but because it's saying 150, it'll be a little bit less. Can that have an effect on clinical outcome? Well, yeah, technically that could cause more hyperglycemia potentially, but also it's going to, be impacted by level of physical activity, by what's eaten. And so really, that is zone B. And then you can see they all fell into those two zones with the exception of like a couple of readings were in zone C, or 9 readings were in zone C, but only 0.2%. So I have gone through so much information today, but just to kind of summarize, we've gone through all of this data. You can see that CGM in many of the studies has shown positive benefits. And one thing I do want to clarify, though, especially when you look at like the concept study, which had those most robust outcomes, is that technically, the women were advised to do this in addition to SMBG. So that I think is important to know. Whether all the women actually did that is another point, but they were advised to do that in addition to. So at this time, when we're using CGM, we're not throwing the meter out the window. And we'll talk more in part 2 why that is and why we still need our women to hold on to their meters. The guidelines you can see recommended CGM as an adjunct to SMBG and not to replace it at this time, but definitely did support its use, especially in women who are using insulin during their pregnancy. And then we got a glimpse to see how the data is viewable in real time and also provides alerts to allow to make, treatment changes in the moment. And these are references as well as different permissions that are listed for the slides. And at this time, I just want to thank you so much for attending and hope that you can make it to part 2.